All right, good morning, everyone. Welcome to the Performance Health booth. My name is Shawn Burger. I'm a physical therapist currently practicing in Northern California. I have been practicing for about 20 years, have both entry-level master's degree and then a transitional doctorate degree. I have been involved throughout the continuum of care. I have worked in acute care hospitals, I have worked in long-term care facilities, but where I really cut my teeth is in outpatient orthopedics. And so with a background of heavy manual therapy and utilizing a broad spectrum of techniques and tools, whether it be hawk grips, instrument assisted techniques, dry needling, and so forth. One of the things that's very common for most practitioners is to come out of school well versed in therapeutic exercise. So we know what isotonics are, isometrics, things of that nature. We can progress patients through eccentrics to concentrics and so forth. Most of us as clinicians, when we get out in the field, we have seen some variation of elastic resistance, various colors, yellow, green, blue, red. We understand the matrix of how to essentially pull on that and create a resistive torque, okay? Elastic resistance has been around for literally decades. What I want to introduce you today, and I've asked for you guys to just be able to have a piece in your hand, is the introduction of the CLX. And for those of you in the back, if you're interested, don't quite have a sample in hand, you can get this over here, for my right, your left. But I'd like you to kind of get a sample and touch it. What's unique about the CLX is that instead of a traditional flat band, which is essentially a single band, we have two bands that have been molded or fabricated together and then created seals or welds every 6 inches or so. And so the CLX, the C stands for consecutive, creating those consecutive loops that we can use to augment where we are doing resistance and pulls and so forth. Now, the purpose of my discussion today with you all, one is to introduce you to CLX. A lot of clinicians have not seen it yet, but also to help us understand that where the value is in CLX is to progress our clients and our patients from traditional single plane exercises to functional exercises, okay? Now, that statement in of itself, I'd like us just to consider. We've done this through therapeutic exercise progression, have patients be doing quad sets, straight leg raises, things of that nature as maybe it relates to the lower quarter. Maybe we have them do glute isometrics, maybe we have them do calf raises. These are all typically done in single plane. But as humans, we are in multiple planes at any one time. We have dynamic forces of pushing and pulling, gravity and so forth working on us. So there is a push in the clinical realm, particularly over the last 5 to 10 years, to really look at functional exercises. So what I want to help us understand is the CLX can help bridge the gap from traditional single plane exercises to more functional exercises, okay? And so we have these consecutive loops. I'd encourage you to kind of feel and touch and so forth. So if we have a client or a patient up here, and for today's discussion, we're going to focus on knee, hip, lower quarter, ankle, and so forth. I could approach this patient and say, okay, we've gone through the clinical assessment, we've identified hip weakness, maybe some isolated knee weakness, maybe some ankle weakness, maybe we've even gone so far to assess functional loss of balance, core stability, okay? Well, we want to look and say, how can we strengthen the hip? How can we strengthen the knee? Well, we can certainly do manual exercises, we can do flat band exercises, things of that nature, but can we look at traditionally from single plane exercises to multi-plane? So I can take something like the CLX in a seated position and just simply loop that around the feet and then come back down. So we've created loops in the system so we don't have to be tying knots. We don't have to try to create this artificial loop and so forth. So now in this position, I can start working on, let's say, deeper intrinsics of the hip, as opposed to the large hip muscles to kind of build a base or foundation before we get into more functional weight bearing exercises. So I could simply, if we were addressing the right hip, ask the patient to just externally rotate right through here. Now, what is she doing when she's doing that? She's actually stabilizing with the contralateral side, and I can just have her do repeated, in this case, hip internal rotation, but at the same time, we're stimulating external rotators on the contralateral side, okay? We could then progress to the opposite direction. Again, my focus might be on right hip, but if I have her now rotate the left hip out, she is now doing what we would consider a reactive isometric to the movement on the other side. So again, right-sided problem in this case. She's stabilizing in a seated position, that hip, and she is now doing, in this case, rotation, what seems again like the uninvolved side, but this right hip is now having to react isometrically. Okay, so we would call that a reactive isometric to hip rotation. And we could repeat that. Now, the ease of the CLX is the fact that look how easy that was to just slip on the foot, no knots and so forth. Could she then take that home as part of a home program? The answer is yes, very easily. Find a place to sit, edge of bed. What if we needed to progress it and make it more challenging? Well, there's the ease of the CLX, because when I set this up, I skipped a loop effectively. So we can quickly change resistance levels by how we position those loops. So I simply, for week 1, have a gap, and maybe by week 2, I've adjusted that up. I've shortened the distance between the loops. We're doing the same exercise, but we've effectively progressed her, in this case, from visit 1 or to visit 2, or from week 1 to week 2, whether she's doing concentric, eccentric motions, or again, the reactive isometrics, okay? So this starts adding to the foundation of deep hip internal, external rotation musculature, okay? Let's slip that off for a moment, and let's go ahead and go into a supine position. Traditional, we'll put Becca's head down at that end, yep. So this is a traditional non-functional position used a lot in the clinic. Because we have mat tables, we're taught to do kind of single plane exercises here. Again, what are we looking at? We're looking at hip, knee pathologies as it relates to transitioning from functional activities. Well, if we take the CLX, which again is a flat band, reinvented, advanced to 2018, we can cut those. So the bands have the ability to be cut and customized to any side. So I've taken a band and just cut it, so I have 2 loops, okay? So now this is my easy dosing for a home program. I don't have to give this long band where maybe they're struggling and knowing what to do with it. So I can take that loop, and I'm just gonna simply slide that over, bring that above the knee, take the other loop, and like a pair of shorts, just slip that on. And then I'm gonna go ahead and take our patient into we'll stay supine, but into a bridge position here for a moment with both sides. So we can now start introducing multi-plane exercises with things as functional as a bridge, which really is kind of a basis of pushing and pulling, getting up from a chair, functional activities. So again, early phase functional activities. So we could do a bridge. Most of us are familiar with that. So I cue her into a bridge and then back down. But by putting that loop there, I can cue her to do a little bit of a push out, stimulating the glute med, creating, again, multi-plane exercises. Now, some of us are thinking, okay, I can just tie a loop around the knee. That's true, easy done in the clinic, but our patients get home sometimes, the loops they tie it in a loop, then they untie it for something else, and they can't quite remember how tight to put it back to. So that loop size changes a lot of times at home because our patients aren't thinking like clinicians. With the CLX, we can just simply instruct them, we want to do a loop by loop side position, and then maybe we want to use a different variation for something more progressive. Okay, so we're taking single leg, bridging there, double leg. Could we progress to single leg bridges? Sure, we could do that. What if we went sideline? So we'll have our patient face away from me. And certainly we could progress into a standard, again, more or less a single plane exercise, kind of PT 101 into a clam exercise. But I want you to consider the value to the patient when you're not having to tell them, well, just tie the band around and create a loop and tie a knot because they may be untying or tying. You're simply giving them a 2-loop CLX and teaching them how to slip it on like a pair of shorts. So I can do external rotation there. In the clinic, I might be able to come in and do manual therapy, my instrument-assisted techniques, if I was so inclined while they're doing that, and start combining these techniques as a precursor to getting more functional. How might I progress from there? Well, I can progress from what we just did, concentrics, to an eccentric protocol. So I could have her come up and hold that. Again, just holding for a period of time, your discretion, 5-10 seconds, and then work on that slow unwinding. Again, very elementary kind of PT 101 exercises for right now, but I want you to consider, again, ease for the patient, the thought process at home. Where can we progress from here? Well, guess what? I could simply slide these all the way down to the ankles, and we'll stay in sideline. And in this position, keep the knees together, but now work the hip rotation the opposite direction. So we're taking that same CLX loop and just sliding to create different lever arms, changing the physics of it. And we can work on hip internal rotation and balancing that with clam exercises. Okay? Different ideas in this level. Now, let's go ahead and slip that off. And again, we want to consider how we can take this to more functional. So let's go ahead and stand up, and we'll take the table away. Thank you. Because ultimately, guys, that's what is exciting about the CLX, is ultimately how do we progress this to something more functional as it relates to hip, knee, and core. All right, I'm gonna ask Becca, can we put one, center 2 loops on your feet? And then let's cross it with your hands and knees, or with your hands. So what I've asked her to do, and I would teach this in the clinic, is to slip essentially the center of a standard band through the 2 feet. Nice and easy, you're not tying loops and so forth. Then she's gonna cross the bands to the opposite side, okay? Now, I wanna have this discussion with us here for a little bit because I'm gonna take you and show you some really neat functional progression exercises here in a moment. But let's just go back to the basics for a moment. Let's look and consider the value of hip extension, which we just did in bridging, hip glute med with a clam exercise and so forth. Could we not take the same patient and put them into, let's say, a quadruped position? And bear with us, I know with her knees, this table is gonna be a little bit hard, but let's go ahead and go hands and knees for a moment. Because obviously in our clinic, we might utilize a mat table or a carpeted area, but now we're creating stability through the trunk, right? So an exercise we do often in the clinic is simply a bird dog, but why not combine it with the CLX, okay? The patient doesn't have to think. We don't have to, again, be tying loops around and so forth. So we could be doing alternate bird dog, left, right. Maybe they're really weak in their core, and a lot of times in the clinic they are, and I will literally just have them stick with unilateral side and just have them repeat just that side 10 times or 15 times, as opposed to going left, right. And a lot of times in those situations, creating needless shear, rotational shear components in that lumbar spine. So I, a lot of times, instead of, again, just so you hear that again, trying to avoid that left, right, and really saying, you know, let's do 2 sets of 10 on one side, let's do 2 sets of 10 on the other side, and really focusing on that stability. An advantage of the CLX, we can start looping it around multiple areas of the body, okay? All right, let's go ahead and stand up here. I appreciate this, not easy getting on a hard surface here. Okay, but the goals, guys, is to get functional. And when your patients come to see you, they complain of hip pain, low back pain, knee pain, maybe chronic ankle instability. I rarely have clients that come to me and say, Shawn, my knee hurts when I'm just, you know, sitting in the car for long periods of time. Some exceptions, okay? My hip and low back, just prolonged sitting. Where does it hurt? It hurts when I get up from a chair. It hurts when I get out of the car, these transitional movements. It hurts with walking, standing. Think about what they're telling you. They're telling you they're hurting actually in dynamic issues, functional issues, okay? So let's take, in this case, our client in that functional position. So now we can go in standing. We set the CLX in the same way. For the purpose of our discussion today, we're looking at right hip, knee stability. So I could simply, in this position, have her stand and just load onto that affected side, the right side, and just go ahead now and abduct with that left leg. So let me ask you here, what hip are we training right now? Both. I see some of you pointing to the right. The obvious answer is yes, she's working on the left. Is she balancing? Yes. Is she working on core stability? Yes. Are her quads activated? Sure. Hamstrings? Sure. Erector spine? Sure. Glute med? Yes. So we are actually stimulating and activating hundreds of muscles in an upright functional position utilizing the CLX. Could we do a traditional flat band with this? Yes, but it's a lot harder in your transitional setups. And it's a lot harder if you're giving someone multiple exercises at home to say, well, do this at home with bridging and supine and then transition to function. They're tying the band left, right, up, and down. It's a lot harder, okay? Now, what if we transition to the other side? Now we close chain left side because she came in here with a right hip problem. And what if we, now instead of just doing the same exercise we just did, what if we just had her step forward, step to the side, almost like in a star pattern? So step forward, step to the side, and then step into extension. So she could work, and whether you do that 3 points or you want to do more of a clock, again, what hips are we activating here? The answer is bilateral, right? So she's closed chain on one, she's open chained on the other. And that's the idea, is that we're staying with functional movement patterns, and I could easily encourage and do that on both sides, okay? Let's get more functional than that. What if we went down into a squat position, okay? So now in this position, I'm loading, and I might ask her to essentially do side-to-side walking. So again, we're activating both sides, and she's gonna repeat that. So her home program, again, may progress from sitting-based exercises, supine or sideline-based exercises, into functional exercises, okay? Could I then work, let's say she's coming in and she's a cashier, and she's having hip and back pain as she's moving things in a cashier at a grocery store. Maybe it's not that simple. Maybe they're an athlete and in defensive things, soccer recovery, basketball drop step for recovery, things of that nature, volleyball recovery. So I can teach these kind of dynamic hip motions by having her come into this squat here. She's controlled with her arms, and we can do isolated drop steps. And you can decide how much knee flexion do I want to do, how much load do I want to do. Again, I'd like you to consider the functional mechanism of what we're trying to do. What is the patient's goals? Are we treating both sides? The answer is yes. We can do that to that side. We can stay closed chained again on hypothetically her right-sided issue and drop step to the other direction. Drop step to the other direction. Okay, so just different ideas. What if that was a little bit more too challenging? Could we not slip that up around the knees and essentially shorten the lever arms? And I'd hope the answer to that is yes. Okay, and maybe in that situation with the advantage of the CLX is you maybe say, you know what, I want to keep a little bit more load on the shoulders in the back extensors, so I could have her stay here. I might even have her with her hands shorten up the loops, even 1 or 2 loops, and it's because we've essentially given her more band to work with, and she could do those same exercises. She could do side to side, she could do some prolonged squatting and coming back up into that position. Okay, what if we wanted to go overhead? What if we wanted to go from a squat position all the way into an elevated stand position? We can do that with the CLX. So let's go again. So we're gonna go down, we're gonna lift something, take something off the floor, we're gonna go all the way up and raise it up over the head. Down to the floor. So the idea of getting into functional activities. Okay? Much more challenging to do with the traditional flat band. CLX gives us a lot of advantages in that regard. Okay, Becca, let's go ahead and slip those completely off. Now, let's try doing some more isolated, but yet still relevant functional exercises. I'm gonna ask Becca to come down, right side again, right knee, we're gonna face that way into a half kneel position. So sometimes we forget that a half kneel position is the same as standing. We've just shortened the lever arm. We've taken one link out of the chain. This, as far as functional activities on her hip, hasn't changed anything from when she's standing. We've just reduced load, or reduced torque, I should say, by removing that lever arm. So she's already, to some degree, stabilizing. The lack of challenge for her is that she's fit, okay? Some of our patients, this right here is a challenge for them. But if we take the CLX in that position, and I'm just gonna loop that into her hand, and she's gonna interlock her hands together around that loop. Now all of a sudden I'm here as a clinician, I can be in here pulling. Now yes, again, a flat band could work for this. The advantage of the CLX is, again, she's gripping on that loop, she's having to stabilize. Now I'm gonna challenge her lever arm here to here is shortened. If we extend that arm all the way out, that increases that lever arm, increases the challenge. So I'm gonna take her back into the shortened position. I'm gonna come all the way out here to induce more load through that resistance, and then ask her just to push straight out. And then back in. Guys, this exercise, what we would call a core push out, is significantly engaging her abdominals right now, her hip extensors, all the hip adductors, the hip abductors on both sides. Her foot, if we were to keep doing this on her left side, that's closed chain on that, her toes and intrinsics of those feet are gonna start digging in. They're trying to essentially grab and stabilize through there. Now, she's like, can we stop that one? Let's push straight out now for a moment. And now let's take that arm straight above your head. So now in this position, and then back down. So if she goes over the head, what does the force of the band want to do? It wants to pull her laterally, right? So now we're gonna pull in the obliques into those hip structures, okay? What I like about, we're gonna rest for a moment. I'm gonna give you the other band. So now we're gonna just give the other loop and for the other hand. So now she has a loop in each hand. Again, we're trying to look at functional exercises here. And we're gonna go straight out, and one arm's gonna go above your head, and one's gonna go into extension behind. So like this. Yes, okay? So this would be secured either by the therapist in the clinic, or if you have the ability to have like an anchor to like a CLX wall station, this could be set up here, and the patient is working on opposites, extensions with the upper core. But I would encourage you guys to maybe consider trying this one time. Her hip right now is screaming. Her legs are screaming, her hips screaming, and so forth. She's getting quite a bit of workout through that hip. All right, thank you. All right, let's come on out of there. So again, I want you to think about functional exercises that a half kneel is a modified standing position. okay? Now, let's take her into standing, okay? So, the traditional approach of knee pain as it relates to hip pain might be to introduce early phase exercises like a quad set. Those of us that are fresh in school will learn exercise progression, progress quad sets, straight leg raises, hip abduction, multi-plane. What is a quad set? It's a short arc tightening of that quad, trying to work that knee into extension. Now, there's nothing wrong with the exercise. There's a time and a place in early phase, but it's not very functional. Doing a quad set over a towel or a pillow, things of that nature on a table is not very functional. And for those of us, if you've never done it yourself, sometimes there's a little bit of difficulty in understanding the movement patterns. A lot of patients will prematurely extend their hip. They can't quite feel it. So one of the things I like about the CLX is I can just loop that around the back of the knee, and I can pull that and anchor that off again to the CLX station. Now the band right now is trying to pull that knee forward. So what kind of patients? It might be dysfunctions in runner's knee, jumper's knee, these type of chronic dysfunctions, but this could also be appropriate for post-op, total knees, arthroscopic conditions. But by that cue pulling her forward, she can now work on driving that knee back. This is a standing or functional quad set, so we could indicate that, and she's just doing terminal knee extension. Now, she's doing what most patients are gonna do, which is going to de-weight as much as possible. They're gonna put as much weight onto that other limb as possible. So our progression in the clinic, guys, is gonna be to cue increasing weight bearing. So do more and more weight bearing. I love how in cueing where she's up on her toe, but the idea of a functional exercise. How might we progress this? We could have her close her eyes and bring in more of a balance component, okay? Things of that nature. We could take her onto an unstable surface. So now we're adding a stability pad or an unstable surface, and she's now having to progress that terminal knee extension, that functional exercise, okay? So to rehash where we went, we started with basic hip exercises in supine position, cutting the loop, going through bridging in clams, in hip rotation, in sitting, and then in supine, then look to get more functional standing, simple hip abduction, closed chain, open chain, stepping patterns into pre-gate and post-gate activities. We did quadruped, bird dog, and things of that nature, then half kneeling, and then standing. Now the last thing I want to show you guys today is how we can bring multi-plane strengthening in utilizing the CLX. So when we're talking about multi-plane, we're talking about forces that are going in 360 degrees. And what we can do is what we call is loop training. So I'm going to have her come forward, and I'm simply going to take that loop of that CLX, guys. I'm going to come in and around the leg, and I'm going to bring that band through the loop. Again, something not easily done with a traditional flat band. And then what we do with what we call spiral techniques is we always wrap in the direction of failure. Where do hip and knee dysfunctions fail? Into knee valgus, okay? They tend to glute med inefficiencies, excessive pronation, and so we're gonna wrap into the direction of failure. So we're gonna wrap this limb multiple times, and that's gonna create a torque curve, and then we're gonna take one of those loops off to the opposite foot, okay? And we're gonna ask our patient to come into a partial squat position, okay? So as soon as she does this, that band right now is wanting to pull that knee, that spiral technique is trying to pull that knee into that dysfunctional plane, okay? So we can't do this very effectively with isotonic equipment at all, okay? It's very hard to reproduce this. So she's feeling that failure. So where do we go in regards to rehab? Back to functional exercises. It may be as simple as just side walking and keeping that knee from failing. Okay? I'd encourage you, if any of you want to try this, we have samples, we can try this here. And then we can progress from there, we can progress right back into that drop step. And we can do that to both sides. What I like about the spiral techniques with CLX training is that if I'm a therapist working on functional exercises, maybe she's a volleyball player. Maybe all of a sudden I have her now in this position, getting ready to bump or set, and I'm tossing her a ball, and she's hitting it back to me. So now I'm tossing, she's hitting it back, I'm tossing, and she's moving side to side. So she's going left, right, and I'm tossing a ball, and she's bumping, she's hitting, setting, whatever dynamic activity we want her to do, okay? So we talked about standing side by side, and then just again, deep functional squat, and we can look at eyes closed, eyes open, but we can also work on step forward and step back. It doesn't have to be always a side to side motion or always a stepping motion, okay? So again, last kind of summary here, I hope you guys grab a sample of the CLX, start playing around with it. Open it up, feel it, understand that we can loop it, or we don't have to create loops. We can use the already existing loops as handles, and we can progress, like I said, from traditional single plane exercises to very functional weight bearing upright exercises, and kind of tie it back to the goals of the patient.